Good afternoon, everyone. So thank you very much for taking out time and joining for this public consultation. So as you're aware that we had hosted a consultation paper on the concept of value-based care, primarily beginning to make some initial steps towards value-based care by looking at predominantly the incentive structure that we want to sort of reform within the PMJAY ecosystem. It's in this line that we wanted to, we were seeking comments from interested stakeholders, but we also thought that it might be good to have this kind of interaction whereby we can present the content of our consultation paper and seek your opinion as well. We've had two sets of consultations with the public hospitals and the state health agencies, as well as the private sector. And this is the third in the series, and we might maybe have one more additional one. So with that kind of a background, before I introduce the consultation paper, I'll request my colleague, Dr. Sudha Chandrasekhar, to give her opening remarks.
Good afternoon, everyone. Thanks for joining today. I think this has been a good exercise and a practice that we are setting up at the NHA to, test and take feedback on various new reforms that we are looking at, because it is very important that as we are starting these initiatives, we also need to do some kind of a litmus check with regarding the operational feasibility and also, how do we improve upon our ideas much further. So in that sense, what we have tried to do as a part of the scheme implementation is to also try to move from the quantity-based performance assessments to a quality-based performance assessment. Here we have tried to see from various international experiences of how we can move towards such kind of value-based initiatives. In that sense, our current accreditation-based incentives, we are trying to refine them further to a performance-based incentive along with some weightage to the accreditation-based using certain tracer indicators. So since we are looking at multiple stakeholders who are involved in this implementation of the scheme and the different sources of information we need, we are trying to make sure how we can make this broad-based consultation with all the stakeholders. And we had a very good participation, I think, day before yesterday, with more than 400 plus participants in the first session and over 200 plus in our second session. So in that sense, we feel that we've got a lot of feedback and we have been able to clarify, even for ourselves, certain things that, we can improve upon. So with this feedbacks, we are very happy to have the third round of consultation with academia and research organizations and private people and development partners who have been supporting all our initiatives. So in that sense, we will use this opportunity and take feedback to improvise on our proposed reforms. So over to you, Dr. Shankar, and we'll be able to answer all your questions at the end of the session.
Sure. Thank you very much, Dr. Sudha. So I'll try and share my screen. And by the time I'm loading it up, I'll request that if everyone could please keep posting their comments and suggestions in the chat box or in the Q&A box that must be there on your on the taskbar. We will take each of the comments at the end of the session, because we do understand that sometimes it may not be possible to give opportunity and to unmute and speak. So we'll try as much as, we'll definitely cover all the questions that are posted in the chat box. So please do typing in and sending them as I speak as well. But just to say that we've also provided a link for a Google link on the website where the consultation paper is hosted on the PMJAY site for people to give in on a formal basis as well. Although all the comments that would be posted as part of this this webinar as well, we will collate all of these comments and suggestions, and we will draft responses to each one of them, and we'll host them all the replies on the website for everyone to see. And we had earlier also hosted a consultation paper on provider payments and pricing, and we had followed the same process, and the responses to each of the nearly 300 plus comments that we had received, we had prepared detailed responses and we put them up on the website. So in this particular paper, what we talk with, we have two sections that we have created in the consultation paper. The first is on value-based care, which I recognize is not a very detailed view of what potentially can be done within value-based care. But these are some propositions that we have outlined in terms of the different interventions, activities, or instruments that we're trying to build in, that either already exist or we are trying to build them in as we go along or in future as well. But I do understand that there is a very broad set of fundamental reforms in the overall scheme design itself that perhaps would need to be considered as we talk about value-based care in its entirety. So as a result, you would have to take it with a pinch of salt that maybe not everything under the sun, or what classically would be referred to as a value-based care, would perhaps be covered as part of the section 1. And the section 2 would talk about much in more detail about the incentive structures. So basically, as Dr. Sudha was also mentioning to begin with, that we are trying as much as possible to bring in some kind of a value proposition in the way that the providers get paid. The traditional methods have focused primarily on either quantity of services, or in some cases, they do not necessarily even look at the quantity of services as well. So for example, in kind of capitation-based payment methods, you look at the number of population covered, does not necessarily take into consideration the volume of services also being delivered. However, in some other methods of provider payments, you do look at the quantity of services delivered, and based on that, you make the payments. In our current method of provider payment, which is a case-based bundled payment as well, we follow the same method. However, what we want to move towards is a more value-based payment system, wherein we not just recognize the volume of services being performed, but we also look at the outcomes of those services within the patients who are getting treated, and look at the broader contour of the quality of care that is being delivered, and based on that, the providers are paid. And this is I know that a lot of you who come from academia and research background, it's not a new thing for you to know, but just to reiterate the importance of quality in the entire discussion, where there's been a sufficient evidence now that how much of contribution does quality have in the overall outcomes of patient care and the overall population health, where there was a Lancet commission which actually gave some estimates of the total mortality that is amenable if the healthcare services are provided in a quality fashion. And the way it quantified between the proportion of deaths that are attributable to a lack of access versus the deaths that happen because of poor quality care, the ratio is 40 to 60. So quite a large proportion in low middle income countries, the amenable mortalities could be attributable to poor quality care. So this is something that is very fundamental, that it's important that we take quality into consideration while we design such programs for delivery of healthcare services. And there are quite a number of different initiatives under the PMJAY also that have been put in place to incentivize quality, which are both financial as well as non-financial nudges. So for example, if you look at the first, if I move from the left to the right in the table below, so we're trying to make a concerted effort to try and establish quality cells at each of the state health agencies, which work with the empaneled hospitals in order to do some supportive supervision and use some standardized tools such as audit checklists, etc., and try and help the hospitals to adopt certain minimum level of infrastructure standards, as well as adopt certain processes, both in terms of delivery of care as well as documentation, that are reflective of a good quality care. Other than that, we have also created a system whereby we encourage hospitals to get certified based on certain standards. There are some existing standards which are governed by the NABH, but there are other standards that we've developed within the PMJAY ecosystem, which has been done in partnership with the Quality Council of India. So hospitals are ranked in terms of bronze, silver, and gold, and this is a certification that they have to obtain based on some application process. So each of these bronze, silver, and gold certified hospitals are entitled to certain financial incentives. So their prices are 5, 10, and 15% higher than what is the standard rate for a given procedure. And in this there is some degree of mapping between the quality standards under the PMJAY and the NABH standards. So the silver and the gold correspond to the NABH entry and the full accreditation levels. And for the public hospitals, we specify that a public hospital that is NQAS certified is equivalent to a gold certified PMJAY hospital, or in other words, an NABH accredited hospital. So a public hospital with NQAS certification is also entitled to a 15% additional incentive. But other than that, there are other non-financial nudges also. For example, recognition of doctors and hospitals that perform well, and quality is one of the parameters that is looked at. Similarly, focusing on messaging around quality of care in the celebration of different international days that we do. And more recently, we have tried to set up certain standards for NABH Center for Excellence, and this is especially in the field of super specialty care. So as I mentioned, that these are the kind of financial incentives that come along with certification or accreditation process. Now, moving towards a generic value-based care, it has a number of different advantages or objectives that it wants to achieve. So it aims at improving the overall quality of care. With better quality care, it hopes to achieve better outcomes in terms of the patient, in terms of the health of the population. It creates an environment whereby providers become a part of the overall care process and help the patients to improve their health condition. There's a lot of emphasis on standardizing the processes, whether these processes are related to the IT processes, whether these are related to the care processes by following standard treatment guidelines or standard treatment workflows, or these are related to processes whereby you navigate through the entire insurance process. So all of these are things that are targeted. And eventually the idea is to ensure the highest level of efficiency, both technical as well as allocative. So if you look at different lenses, different perspectives, there are different value propositions for a value-based care. So in terms of an individual or at a personal level, a value-based care would imply on that the care that is being delivered is such that is evidence-based, has the highest clinical effectiveness, and also which is delivered in a way that respects the patient dignity, responsive to their needs, etc. From more of a payer's perspective, it involves that the value proposition is that it should bring in efficiency. That means you're able to maximize the amount of health that you're able to gain given the amount of resources that you spend. And from a allocative societal objective point of view, you want to ensure that the overall allocation of resources follows a more equitable pattern, both in terms of the regional distribution of resources, in terms of distribution across population subgroups within a given state, etc. And then eventually, all of this makes sure that a healthy population is able to contribute back to the society. There's a higher social participation as well. So given this kind of a broad framework, there are different ways in which the value-based care is being either practiced or being conceived to be incorporated, or some plans are being developed in order to do that. And I'll try and move in a clockwise manner from the top right, where we want to have integration of care delivery. So we're trying to work closely with the Ministry of Health to try and ensure that there are opportunities of continuum of care across the different levels of care, starting from primary, secondary, and tertiary healthcare. And we're trying to ensure that there is some kind of a communication dialogue for the patient, up referral, down referral, between the two pillars of Ayushman Bharat, which is the health and wellness centers and the PMJAY. We've also introduced, as part of our new health benefit package, follow-up packages that ensure that once the care is delivered to the patient, we don't necessarily stop at that point, but we also ensure that the follow-up care, for example, in procedures which are there in cardiology, cardiothoracic surgery, urology, etc., where the patient outcomes need to be monitored beyond the surgery after the discharge from hospital. And there have to be certain diagnostics, certain medications that the patient has to adhere to, etc. So those follow-up packages have also been created. More daycare packages have been added, specifically, for example, in the specialty of mental health, where we do recognize that we do not necessarily encourage a hospitalization for every patient who suffers from a mental health condition. And as a result, you require certain care that is to be delivered in a manner which involves detailed kind of psychometric assessment or psychoanalysis or counseling, and also some kind of a pharmacological or non-pharmacological therapeutic care. And then, as I mentioned, we're trying to establish quality cells, use audits, etc., to ensure that there is such continuum. We are trying to also work on expanding the geographic reach of the providers. We have incentives for hospitals that work in that operate in aspirational districts, which are the hard to reach or vulnerable areas within the country. So there are about 116 such districts that have been identified. So there's a 10% higher price for each package, which is delivered at hospitals located in aspirational districts. And we have now recently introduced a differential pricing, whereby the prices of that are paid to hospitals are differential based on the location of the hospital, whether it is tier 1, 2, and 3, and whether it is a tertiary or a secondary. And in doing so, such a differential pricing, we have actually tried reducing the actual amount of gradient that exists between tier 1, 2 versus a tier 3. So which means that while we do give a higher incentive to we give a higher price to the hospital located in a metro city, for example, or the 8 tier 1 cities. However, the extent to which the cost of care based on actual evidence is more in those hospitals, we're not reimbursing them to that level as well. So which means that in a way, there is some degree of incentivization there as well to hospitals that are located in tier 2 or tier 3 cities. There is a lot of emphasis on the IT construct of the overall scheme delivery. Our entire scheme operates on a transaction management system that enables a complete paperless transaction. And the work on the Ayushman Bharat digital mission is trying to take it a step further by trying to integrate different pieces of the providers, the payers, and the beneficiaries. And the providers also could be of a wide different variety, not just the ones that are within the PMJAY ecosystem. So these could include the pharmacies, this could include the other things. So which means that there would be a mechanism to track the information and to track the outcomes beyond the point of hospitalization as well. So, which is one of the limitations so far in the proposal of our even our incentivization that I'll talk about later. But I think that moving forward, the ABDM might provide opportunities to even expand the scope of monitoring the performance of services that are delivered, even beyond once the patient is discharged, or even before that as well. So we're also trying to work on performance-based payment systems, where it is, so the value-based incentive is something that I'll talk about, and a DRG-based payment system, a pilot for that has already been started in 5 states, and we will have a process of data collection, patient-level cost data collection from hospitals, both public and private, in order to try and see that how much differentially one should be paying patients of different levels of severity for the same package of care that is being delivered. There's also a very concerted effort towards establishing a systematic process of measuring costs and outcomes, whereby a health financing and technology assessment unit has been created within the NHA, which will work in close coordination with India's HTA agency, which is the prime body to actually generate evidence on cost effectiveness of newer technologies, drugs, devices, etc. And we would follow the recommendations by the HTA agency in order to make decisions on inclusion and pricing of new new drugs, devices, etc. So the role of this HEFTA unit would be more to sort of receive nominations on topics that people would like to suggest for inclusion within the health benefit package. But then it would ultimately work in close coordination with the Department of Health Research HTA agency in order to use the evidence that is generated from that side. And then there is a whole range of work that is being done in order to make sure that there is a liaising with comprehensive primary health care and looking at the entire care delivery as not just individual services, but as a bundle of the overall services that have to be delivered in order to treat given medical conditions. So a lot of work on the HBP design, etc., that goes on in this particular sphere. So this is what we try and articulate in the first chapter, which I completely concede that would not be something that would be the overarching view of what a value-based care could be. But it gives some bird's eye view of what are the interventions that are being thought, what are the ideas that are being conceived, and what is it that lies in future in order to move the entire PMJAY ecosystem towards a value proposition. So we are inviting comments on different aspects related to the comprehensiveness of the approach that has been outlined, and different aspects that you feel should be added to the overall framework of the value-based care that I tried showing to you, and then giving us an overall feedback on the overall policy of these value-based incentives. So this is what has been shown in the first chapter. The second section of this consultation paper basically talks about in more detail about the kind of incentivization that we are proposing to introduce after a pilot, both in terms of outlining the indicators that we have chosen to incentivize the providers and to measure the performance in the first place. And then subsequently, it highlights or it elaborates the process through which the data would be collected for each of these indicators and how the computation is likely to be done for deriving each of these indicators and measuring the performance. So just to set the context, these are the set of factors on which the current incentive structure is actually created. So we have our incentives that are mostly given to hospitals on the inputs and infrastructure which come through either accreditations or certifications, or there are incentives that have some social policy objective like an aspirational district, a metro city because you want to compensate for cost differentials, or there are other policy objectives that you want to incentivize creation of health workforce. So you want to incentivize or give greater price to those hospitals that also have a teaching function in that. However, with the new differential pricing system, the differential pricing does take into consideration the possibility that a procedure is a tertiary or a secondary, as well as the fact that you have a hospital that is located in either a tier 1, tier 2, or tier 3 city. So these two incentives would possibly go off once states migrate to the new HPP 2022. However, one of the problems with this incentive structure is that all of the incentive is around inputs and infrastructure largely. So what we are proposing to do is that we want to increase the contribution of incentive that comes through a measurement of performance rather than all of the incentive being calculated through certification based measures. So what we are proposing in the beginning is a kind of a 50-50 percent share of the incentive amount that gets estimated through either certification or through outcome based incentives. But the key question here is that how do you define how do you define these outcomes? Or in other words, how do you choose or shortlist the indicators based on which you measure the performance and determine the outcomes? So in order to do that, we first tried outlining the criteria that we would like to choose, that we would like to frame in order to choose the indicators. And the three set of criteria that we shortlisted. The first is that we wanted that the indicators that we choose should broadly be reflective of the broader principles of universal health coverage, and should also align to the broader health systems performance measurement metrics. So that's the overarching criteria. But then we have two sort of logistic criteria as well, that the indicators that we choose should be such that are easy to be collected. They are based on certain data that can be readily collected, do not impose too much of effort to collect that data. And thirdly, whatever data that we collect, there's an internal validity of those indicators, and it's not possible for providers to easily maybe game that information or make those changes. So there's not much potential for a bias that can be introduced by the person who's actually inputting the data. So given this background, we then tried looking at which are the three major domains of universal health coverage. And we realized that they are either a responsive patient-centered care that is delivered in a manner that does not impose any financial hardship and ultimately leads to better health outcomes. So linked with each of these three domains, we identified indicators. So for the first domain, we identified indicators which include the level of beneficiary satisfaction and the presence or absence of a confirmed grievance. For the second, which is financial risk protection, we're looking at out-of-pocket expenditure. And for the third, which is health outcomes, we're looking at two indicators: A, the readmission rate, and the second is the improvement in health-related quality of life. So I'll now try and describe what each of these five indicators mean and how we propose to collect data on each of these five indicators. So these are the five final indicators that we have chosen. Not to say that there were not other indicators that were widely discussed and debated. There were three other important indicators that were very strongly contested, and which are valid in their own right, in order to develop any kind of a quality measurement framework also. So for example, hospital-acquired infection is a very strong indicator that is used to measure the quality of care. And this is used in a variety of different settings to measure the quality. However, we do recognize that there is a strong possibility of a bias that can be introduced in this data that might be collected, given the fact that it is going to be used to measure performance and then to provide incentives. So there is likelihood of a reporting bias and a likelihood of significant underreporting if this is used as a metrics for providing incentives. The second indicator that was again discussed was mortality. And while we do recognize that mortality is a very important outcome indicator, we do also recognize that mortality is confounded by a lot of other factors that go beyond the quality of care that is being delivered. And even if we drill down to disease-specific mortality also, in order to make sure that the patterns of patients that are being seen in different hospitals, they are distinguished based on the disease-specific mortality rates. Even then, if this is considered as an indicator, then there is likely to be a perverse incentive among the hospitals to specifically cream skim the cases that are likely to be of less severe category. And there is likelihood of a denial to patients who are of a greater severity spectrum. So as a result, again, this indicator was not considered favorably for inclusion to be used for devising an incentive structure. And the third indicator, again, length of stay. It's argued that you should have shorter lengths of stay, both from an efficiency point of view and for clinical outcomes point of view, because we generally recommend patients to be made ambulatory as early as possible for better long-term outcomes, etc. However, again, this was not considered favorably, because this may again lead to a perverse incentive whereby the providers would discharge patients early despite they requiring longer hospital care, given the kind of complications, comorbidities, or some kind of severe disease spectrum. So while we continue to use these three as important indicators to measure the quality of care which is part of our framework as part of the quality checklist that we use in the hospitals. However, this is something that we have not yet that we have kept out of the overall scope of the incentive calculation. The overarching condition is that there should have there's a conditionality for any hospital to be eligible to avail the incentives, and that is that there should be no case of fraud against the hospital. And if there is any case of fraud, then there is no incentive consideration for that hospital. So coming to each of these indicators, so beneficiary satisfaction rate, there is a current process there's a call center that is established within the scheme, which makes a follow-up call to each patient who is discharged on the second day of the discharge as well as on the 15th day of discharge. And on the second day, they ask this. They used to ask this question on the satisfaction, how satisfied the beneficiary is. We're just trying to reform this question to make it a little bit more objective by introducing a kind of a visual analog scale, whereby a patient is able to report quantitatively that what is the level of satisfaction. And once it is calculated, we would estimate an average satisfaction of patients in a given hospital. And the the class intervals that we have calculated is on the higher side, considering that we know that in the experience from most patient satisfaction surveys reflects that majority of the patients report that they're satisfied. So as a result, we have not started the spectrum of our marking system from 0 onwards, but we rather started more on the higher side. So the ones that get a high marking on this particular domain are those hospitals that get a beneficiary satisfaction score that is upward of 85%. The second indicator is readmission rate. Now we know that there are potential challenges even in using readmission rate, but what we are classifying as readmission case is a case who gets readmitted for the same disease condition within 30 days of discharge from a previous episode of hospitalization. And we do recognize in certain cases this may not be applicable. So for example, daycare packages, dialysis packages, chemotherapy packages. So in such cases, we will not include this particular indicator for the measurement. And for such centers that only deliver these type of services, the overall incentive would be calculated based on the remaining 4 indicators alone. And here the benchmarks that we have kept are based on certain international literature, which recommend that what is the sort of acceptable level of readmission rate. The third indicator that we have was on financial risk protection, whereby we want to measure or assess whether there has been any out-of-pocket expenditure that has been incurred specifically on the direct medical care that was delivered at the hospital. So which means that any charge that was levied to the patient in the hospital for a package reserved under the PMJAY, where the patient had to pay for either drugs, diagnostics, consumables, or any kind of a user charge that was levied. This does not include any cost that the patient might have borne on travel, or maybe the boarding and lodging of the relatives or the caregivers for that matter. And here the marking scheme is such that we do not give any mark to if there is any out-of-pocket expenditure, and a full mark if there is no out-of-pocket expenditure. Now, again, there was a discussion around that given the fact that the policy itself says that the empaneled hospitals are not supposed to charge any expenditure, then why even keep this within the overall framework of performance measurement? The reason why we still want to keep and retain this as part of the measurement metrics is A, obviously it reflects on the overall UHC objectives. 2, in the current system where if there is a grievance that is reported by a patient who says that there is an out-of-pocket expenditure that he or she has incurred at an empaneled hospital, if the inquiry establishes that there was an out-of-pocket expenditure, then the hospital is made to pay back that amount to the patient. So which means that or if this is a repetitive nature, then there is some other additional punitive action on the hospital. So, but the point is that the hospital is kind of penalized in that particular individual case itself. However, on inclusion of this indicator within the performance measurement framework, the penalty of having made an out-of-pocket expenditure is restricted, is no longer restricted to the payment that he or she receives for that care episode that is delivered, but extends even beyond that to patients, the other patients also where the care, where perhaps even there may not have been any out-of-pocket expenses. So the incentive amount automatically comes down for the other set of packages that were also delivered at that in that hospital. So in a way, it kind of re-emphasizes and places a higher emphasis on the fact that the scheme has a zero tolerance policy against any kind of out-of-pocket expenditure. For a grievance, there is an established mechanism to receive grievances from the hospital, from the patients, whereby they register their complaints through different mechanisms, either directly going to the grievance redressal and management system portal that has been established, or even if it comes as a written or an email complaint or a call center complaint, that it ultimately gets registered into the CGRMS where an assessment is undertaken. And again, the scoring is that if there is a confirmed grievance, then again the hospital does not get any mark for this particular parameter, whereas he gets full marks if there is no confirmed grievance against the hospital. So till these 4 indicators, we have current established methods of data collection that would enable computation of these indicators. So right now also these systems of data collection had been put in place, just that they were being used as well to an extent, but maybe they were not being used to that extent to perhaps even generate a feedback for the hospitals as well. But perhaps this emphasis on value-based incentives will further help to improve these already existing systems of data collection, and we will improve the methodology of their data collection as well. The last indicator, which is the improvement in the health outcomes, is where we will have certain additionality of work to be done to collect additional data. And in this particular case, we are trying to, what we're trying to measure is that what is the functional improvement in the quality of life of the patient following a given episode of care that he received at a hospital. And in order to do that, we're trying to make use of the tool, which is the EQ5D5L, which basically measures the performance or the functional quality of life of the patient on 5 different domains, which is mobility, self-care, usual activities, pain, discomfort, and anxiety. And the job is to basically record the response of the patient of how he feels at the time of admission on each of the 5 different domains. And once you receive the responses, then you generate a profile of the health state. And as of now, based on a study that was commissioned by the Department of Health Research, a value set of based on this EQ5D5L has been generated for Indian population, which provides a quality of life score or a utility score for each of the different health state profiles. So this value set will be integrated within the IT system through an API linkage, whereby whatever is the response that is generated from the patient's elicitation would automatically result in a valuation that would be given in terms of the quality of life. And this valuation would result into an index value of quality of life. And this valuation would be done at 2 time points. The first is at the time of admission, which will be done by the Arogya Mitra. And then on the 15th day of discharge, when there's a call by the call center, again, the same question would be posed. And the relative change in the functional status would be assessed. And the hospitals would then be, their performance in terms of the patient outcomes would be assessed not on absolute basis, but on relative basis. So we're using here a percentile-based approach towards improvement in patient outcomes, because we do recognize that in some cases there may be less, or in some cases there might be more changes in the functional improvement. Plus, it's sometimes hard to pinpoint or categorize that this much should be the extent of improvement in the quality of life. So what we're saying is that on a relative scale, how is a hospital performing in terms of the outcomes of patients that are treated in that hospital? So that's the approach that we're taking in this particular case. So overall, this is the final summary of this quality of life assessment. So you make the assessment at the time of admission. You do an initial health profiling based on that. Quality of life is automatically assigned. Then during the subsequent follow-up call by the call center on the 15th day, you again ask the question. Again, the same process takes place, and then you generate the relative improvement in the quality of life. We do recognize that this particular thing is also subject to some kind of bias, whereby it is possible that the person who's recording the quality of life at the hospital at the time of discharge, at the time of admission, may report a lower quality of life of the patient. And as a result, we're trying to also create an app which is going to be at least the patients that have the app in their mobile phones. And we know that these days there is a lot of penetration of mobile phones. So we want to place this power in the hands of the patient to actually self-report on a lot of these parameters that we're trying to put in place. So while we do want to make sure that the available avenues of data collection are continually used, for example, the call centers or the PMAMs or the grievance portals. However, we want to also ensure that there is this empowerment of the patient to self-report the information on either the level of satisfaction, any grievance, or the level of improvement in the quality of life, etc. And that, if available, would be the primary source of data that would be used for calculation. Whereas if the data is not provided by the patient, then automatically we fall back on the established mechanism. So implementation, we want to roll it out as a pilot to begin with in a few states. We know that this involves a lot of training of some of these functionaries who are going to be involved in this data collection, and also sensitization of the state health agencies. There has to be certain work that has to be done at the IT level for integration of certain value set, for example, or maybe auto calculation of certain indicators on hospital performance, etc. And then once all of this is done, we want to at least run this pilot for a few months to generate certain data. And this data is, so on an indicative basis, we are saying that it is 3 months, but we do recognize that it may take quite long as well to collect the data, establish baselines, see the kind of potential challenges in collecting that data, as well as potential challenges in the way that people report a given information. And then based on that, articulate a final strategy that is put in place to replace the current strategy of incentivizing. This overall strategy is also aimed at creating a public dashboard for performance assessment of the hospitals, whereby each hospital would be ranked, or the performance could be gauged on each of these different parameters, as well as an overall level of performance. So we hope that this could create a kind of demand side effect. So patients walking in for a particular type of care can actually go and see that which hospitals are performing at what level for the type of care that is being that they are wishing to access. So we want that this portal should not be just a portal for monitoring purpose at the hands of the policymakers or the program managers, but it should also enable the patients to make an informed choice about the hospitals, and that in a way also becomes a driver for the overall quality. So finally, we have a certain set of questions that we have posed for inputs from the stakeholders, including the kind of opinion about the value-based indicators that we have chosen, the proposed methodology that we have outlined for the data collection, the challenges that you feel for each of the 5 indicators, how we are proposing to collect the data, and also the kind of computation methodology and the marking system that we have put in place. And also we invite suggestions on potential other indicators that you feel that we might have missed out, but which should be incorporated in this entire framework. And we would specifically request the information to be provided in terms of the indicator names, why you suggest this should be included, how the data could be collected for each of those proposed indicators, and then how it should be estimated in order to generate a particular value of the incentive amount. So we've, as I mentioned, that this paper is available on the PMJAY website, and a link is provided for submitting your responses. The last date that we have set for submitting the responses is 21st of July, and we would very much welcome you to please deliver your responses. We do recognize in certain institutions there are some restrictions on the use of uploading certain information on the Google Forms, and as a result, we've also placed a spreadsheet, an Excel spreadsheet also there. So you could download the Excel spreadsheet, submit, write your responses, and submit them to us on an email that has also been made available on the website. I'll request my colleagues who are also on the call to maybe type in the email ID where the responses have to be submitted, if they are being submitted as a kind of an Excel spreadsheet or as a Word document. So I'll stop sharing here, and then perhaps we'll now spend time to respond to questions that have already been sent in.
So thanks, Dr. Shankar. Maybe you can have a drink of water and I'll take the first question. So we'll do this alternate so that each of us, will be able to clear all the questions immediately. Okay. So I think the first few are welcome ones. Okay, how is quality in AB PMJAY different from NABH? Same parameters are going to be used. How patient-related outcome measures will be integrated? I think this was a question very early on before the presentation. I'm sure that this has been answered in the presentation. If there are any additional follow-up questions on that, that will be we can address. Yes, NABH is one of the accreditation criteria under which our quality incentives are already being provided, both NABH and NQAS for public hospitals. So we have 3 levels of accreditation there, 15% for full accreditation, 10 for entry level, and 5%, and for bronze certification, we have 5%, and 15% again for NQAS full national level certification. For outcome measures, we have already listed. Maybe there are more outcome measures, then we can discuss it as we go ahead.
So the next is the value-based care. This measurement, would that be done at the doctor level or at a particular healthcare setup? So what we are aiming to begin with is at the hospital level, but our intent in future is definitely to expand it at the level of specialty within a given hospital, and maybe drill it down to even a doctor. However, the current construct of our TMS, we are trying to make it sure that it is sensitive for us to even identify and label providers that are linked with each of the care episode that is delivered. So once it's done, so definitely we want to, even in the short run, we want to go and drill down and have performance listed at the specialty level. But the aim in future would also be at the level of maybe the groups of providers that are delivering care in a given specialty, or even at individual doctors.
Just to add on to that, as we are moving towards ABDM, we are registering all the HPRs, the Health Professional Registry. So we will be slowly integrating that within our empanelment modules also, so that we have a list of all the treating doctors under that facility, and we'll be able to track the treating doctors as they are uploading the pre-auths and the claims. So with regard to what about telemedicine, has gold standard for diseases for each specialty been defined or validated? With regard to telemedicine, what we have said is that in our package construct, it says that any consultation, whether it is the OPD consultation or even consultation through telemedicine, those are covered. So it is a part of the package, but we are not measuring that part here, what is happening in the OPD setting. So whatever we are taking the feedback is overall care, which includes from the time OPD admissions, overall the patient would be responding to his whole experience. But we have recognized the fact that individually diseases, we need to relook at it. So that will be our next phase. So whatever we are talking about is more at a broader conceptual level. And individual diseases, we need to define and validate, because we do know that, and when exactly these measurements also need to be taken, that has to be there, because we do understand that for some without treatment, the patient might be feeling fine. But the treatment there will be some kind of deterioration which he will experience in the first few days. So that should not be taken as as lack of response from for the treatment. So we will be refining it at the package level also, as we go ahead, and the disease condition level also. So that's a work in progress.
So I think the next set of questions would have already been answered in the talk, that what is the methodology of measuring the beneficiary satisfaction and the grievance. So there is a detailed, there's a questionnaire that would be available with the call center, and that uses a kind of a visual analog scale to ask about the beneficiary satisfaction. The satisfaction is not going to be elicited. So it's going to be an overall user experience that is going to be elicited, which may, and when the patient reports on that, he may report based on the kind of care that he receives, but also on the type of other non-care attributes of the hospital engagement. For example, maybe the provider behavior, maybe the hygiene, cleanliness, the type of food quality as well. So that may also get configured in the overall response. That's it. And there is not going to be any, so similarly, I think HRQL is also something that we have specified.
So there'll be no, will there be any penalty if the patient dies? Currently, we don't have any penalty, and mortality indicator will be reviewed as an overall quality parameter of the hospital and a kind of, the outcome measure, but it is not yet linked with the incentive system or, the scoring. So right now we will only be reviewing it as a part of the process, because we do collect that at the time of patient discharge, whether the patient was discharged or whether the patient died. So in that sense, we will be doing that as a separate analysis, and we have initiated that analysis to see how the mortality patterns within our own PMJAY beneficiaries, so that we can identify how we will include this indicator at a later stage.
There's a suggestion on inclusion of disability related information also as an indicator. I think that the way that we measure the quality of life, as I had shown in the tool of the EQ5D, it has domains for physical health, mental health, the social aspect of health, and even the social participation, etc. So it covers all the domains. So if a person is, let's say, having some functional impairment or disability, it would automatically reflect in the level of his mobility. It may reflect in the level of his ability to carry out his daily activities, or maybe perform his social responsibilities for that matter. And that, so in a way, it gets incorporated in the tool. And that's the reason why this particular tool has been used, because looking at disabilities is only perhaps, it may be relevant to certain specialties or certain types of illnesses. However, the EQ5D5L is like a generic tool which extends beyond disease conditions. So it can be cut across different disease conditions. It can be applied in the same manner.
So the number of patients on an average treated by an empaneled hospital per month. I think the number of patients treated is already taken based on the what we are looking at is like for hospitals which are treating very less number of patients. So in that we are taking the details for each of the patient. So it depends on whatever number of patients that we are looking at. Mostly they will be covered in those hospitals. So we are not doing any sampling for this as of now, but we will now initiate to start with. We'll look at every patient, and then we will see when the volume of cases in each of the hospitals are more, then maybe we can look at how do we address that. But right now, our first plan is to include all the patients to rank these, to score all the parameters.
There's a suggestion that indicators for payment will need to be separate for super specialty cancer hospital. So the response is that by and large, we have the same indicators for all types of hospitals. However, in specific considerations where a particular indicator is not likely to be relevant in a particular context, like chemotherapy centers, the issue of readmission rate may not be applicable. So in those cases, we will omit that indicator, and the remaining set of indicators will be used to measure the performance. But to say that grievance, patient satisfaction, out-of-pocket expenditure, or these things should not be should be treated differently for a cancer versus a non-cancer center, perhaps may not necessarily be as justified. The second comment on prevention and follow-up, definitely yes. So in the overall scheme of value-based care that we tried to articulate, we did place very significant emphasis on the continuum of care and the fact that there should be some enough emphasis on the integration between the health and wellness centers and the PMJAY hospitals. And we are trying as much as possible to add these follow-up care packages as well. So we hope that in certain cases where you require a follow-up care at a hospital level, these packages could be used. And in other cases where the follow-up care is to be delivered at home setting or at primary care setting, these functional integrations with the HWCs would enable that kind of follow-up care.
So will there be a mechanism to talk to call center in case of grievance? So if it is grievance from the hospital, recently we have released a call center hotline for the empaneled healthcare providers, wherein both the hospital or the doctors can call and register their grievances or review that. So the new number is 14413. So apart from our 14455, we have which is for mostly beneficiary or inquiries calls that come. So now we have another hotline for the hospitals, which is currently live. So the hospitals can connect at that number.
There's a session on use of or the feasibility of using some kind of disease specific or generic patient reported outcome measures, etc. So see, our intent is by and large to have the same a generic tool. Firstly, that's the first preference, a generic tool that is applied cutting across all kinds of disease conditions, specialties, etc. And the second consideration is that it should be very simple. That's the second consideration. So that's why EQ5D 5L. And the third consideration is that the tool should be such where the scoring has been done, scoring for that tool has been done in Indian population. The only tool that merits all these three conditions, especially the latter, where the value set has also been generated based on Indian population responses, is the EQ5D 5L. So that's why those were some of the reasons that favored choice in for the EQ5D.
Readmission may happen elsewhere, not recorded by the same hospital. So even if this readmission happens with a different hospital, but empaneled with PMJAY, our TMS will be able to track them. But if it happens outside our ecosystem, outside the PMJAY ecosystem, definitely in the current state, we are not able to track it. But again, as we have more integration with ABDM and other HPR's registries, wherein we have the link of all the hospitals within the same healthcare ecosystem, maybe then definitely we might see the possibility of looking at it. But currently, if it is outside PMJAY ecosystem, then we will not be able to. I think that is one limitation. We agree that.
There's one comment on that the cost should also be considered for travel, etc. So since the scheme doesn't cover for the overall cost of travel, it doesn't reimburse the provider for the cost of travel. As a result, we cannot penalize a given hospital for the lack of for the fact that a patient has incurred travel costs. However, we do recognize that this is something that is definitely important, and there are other avenues that are being created by the Government of India and by the state governments to ensure that there is minimal or no cost for any kind of travel or for accessing care, and a whole range of 108 and 102 network of ambulances are being established in this regard.
So investigations which are part of the diagnosis for which the package does include, then they are already considered in the package construct itself. So if some of the investigations are done elsewhere or not within, within the system, or addition to what is mandatorily required in the package, then those would be, we will not be able to make sure that whether it is to be considered as an out-of-pocket expenditure or not for our scheme construct. So as per our scheme guidelines, if those investigations are part of our package requirement, then definitely it is considered as an out-of-pocket expenditure. But if they are optional investigations which we have not factored into our package construct, then it will be not considered as out-of-pocket expenditure. And I think we are trying to see how we can expand this further. I think right now the diagnostics, we are looking at a pilot with the e-rupee vouchers. So this is started in PGI Chandigarh. So we are hoping how it works, and maybe this will also help in cutting down those investigations that happen before the patient gets admitted. So I think this is mainly to address that kind of out-of-pocket admission expenditure. And I know Dr. Shankar wants to say more.
No, I think it's fine. It will digress us from the main subject. So there's a very interesting comment on that there may be a paradox between the optimum standard of care and total prohibition of out-of-pocket expenditure. So I completely agree with the comment, provided the underlying assumption is that the price that has been set does not necessarily cover the overall cost of care. Now, our intent in all our revisions of the health benefit packages is to align the prices to the actual cost of delivering care. And as long as we believe that the price that has been set is representative of the actual cost of care, and the providers have agreed to provide care at those prices, and that's why they've got empaneled, there should not be any out-of-pocket expenditure that should be charged. We are trying to further refine our processes of provider payment by ensuring that in certain cases also, which are complicated, have comorbidities or are more severe in nature, which perhaps may require a slightly more intense treatment, they can be reimbursed at a rate that is different from what it is, or slightly higher than what it is for an average or a low severity spectrum patient. And that's the reform that I briefly touched upon when I said that we are trying to also do a pilot for a DRG based payment system. So we are trying to gradually build this to ensure that there is no need for a provider to charge a patient for anything else.
Dr. Shankar, can you take a couple more? I'll just get back just to take a call.
Sure. So there's a question on the chemotherapy cycle. So would the assessment be done at the end of each cycle? I think it's a great question. So we do what we are hoping. That's why I mentioned that certain daycare procedures, chemotherapy cycles, dialysis, etc., would be a different one. So what we are proposing is that for certain set of procedures or packages where the care does not necessarily end at a given episode of contact between the hospital and the patient, we do that measurement 15th day post the final set of cycle, for example, in this case. So that's the current approach. I mean, I do agree that there are still going to be perhaps certain challenges. Maybe the patient may not be in the most desired point at which you should be measuring the quality of life. So we'll be happy to have more suggestions on that, ma'am. How did we arrive at the 5 domains of EQ5 QL? So these 5 domains of Eurocall. So this is a standardized tool which has been developed by the Eurocall Foundation, which has identified these 5 domains. And these 5 domains, this tool is used in several countries. I can recount more than 30 countries where this tool is used commonly in clinical settings to measure the quality of life across different specialties. And I do agree that there could be other domains beyond these 5 that are listed, which could also be used to perhaps which could also be important to reflect on the actual quality of life. And there's still work that is going on and some research that we are aware about that is going on within India to look at the other domains. We call that as bolt-on dimensions, which could also be potentially considered as an expansion or as an add-on to the existing set of 5 domains. However, this is still not yet finalized, not yet certain. So what we're going ahead with what is the current state-of-the-art knowledge. The next question is that for outcomes, it is important to relate to pre-treatment expectation, prediction, and prognosis. Document the same. So see, for outcomes, what I'm trying to mention is that if we are not looking at outcome at a single point of time in terms of the improvement in the health condition. So the improvement in the health condition, we're trying to measure using a baseline assessment and an endline assessment. And so the point is that if the baseline and the endline assessment are being done for the same patient, then in a way, the patient acts as a control for himself because he's doing so. A lot of other patient level characteristics. So if a patient is like who has high expectations, and so he'll likely self-report a poorer condition of his own health even at the time of admission. So as a result, we hope that there is going to be some degree of the control of characteristics at the individual level, given the fact that we are doing a pre and post assessment of the same patient in order to.
Which question, Dr. Shankar?
So I am now at question by Dr. Manju Sengar, she's asked that this will be dependent on the disease.
Okay, okay. That's done, right? Okay.
So, I mean, this question again, I mean, I agree. So a lot of the outcomes are going to be dependent on individual disease conditions. So that's why we are looking at the outcome, the performance measurement at an overall hospital level. So we're not looking at while we're doing the measurements at individual level, ultimately we are trying to pool it at the hospital level. So which means that we are, if the hospital receives on an average a generic a spectrum of cases that are reflective of the stage and the severity, both from mild and the moderate and the severe. So eventually it will even out. So this is like the same argument that we have in our case-based bundled payment also. So a uniform payment for all types of patients of availing a given package. Again, here the argument is that you might have to spend a little higher in certain cases, but eventually it evens out.
So the quality of life depends. I think that Dr. Shankar has already asked whether it's about the condition and the age of the patient. Yes, age of the patient, again, it is a part of the processes because we will be having that age data. So when we analyze the aggregated level for that hospital, we will also bifurcate the kind of satisfaction scores given by different people of different age groups. So definitely there can be some kind of adjustments that can be looked into with regard to the age of the patient. Because elderly, mostly the attenders would be the ones who would be giving the responses. So there again, there will be some kind of different version, both when the patient reports themselves compared to an attendant reporting on behalf of the patient.
Next comment is, I think we're getting very good comments on, especially on the timing or the way that the patient outcomes are being monitored, at what point they should be monitored. And the next question is also on the same line, that when is the data on the HPQA collected is extremely important, beginning of the treatment and at the conclusion, especially for patients on radiotherapy. So it's exactly the same approach, madam, that we are following. We're trying to do one set of measurement at the beginning and one at 15th day following the completion of the treatment or the discharge. And in cases which involve multiple cycles or like chemotherapy, radiotherapy, etc., we're going to measure it at the end of the treatment after the culmination of all the sessions.
AB PMJAY are only subset of patients, and data availability of all patients. In that case, how to ensure that data on all parameters is collected. So I think it's a sample, our PMJAY sample only we can collect this data. So we are not going beyond our PMJAY beneficiaries to collect this kind of similar feedback or information for other patients who are not part of the beneficiaries under our scheme. So currently we are limiting ourselves. These are some boundaries that we have put in ourselves so that, we will have some kind of a consistent data for our beneficiaries. So we won't be having data from other non-PMJAY beneficiaries.
So again, the question is that why it should be documented pre-treatment itself as to what is the expected movement or QOL post-treatment. So I think we've sort of answered this question. And this, yeah.
So I think RT symptoms may be at their peak and the quality of life may actually be lower at the end of RT. So those are the disease specific characteristics we will have to inbuilt into the package specific kind of assessments. So definitely we will be going back to our experts committees to also, when we are, once we have an agreement on the overall assessment plan, then what we are looking at is which are the packages which can be included for these kind of assessment, which needs to be excluded, and what special conditions or rules need to be applied when we are analyzing the results from these kind of packages and patients. So these are some things we will be developing as we go ahead, and definitely we'll be reaching out to the concerned specialty experts to identify how we manage the data and analyze and interpret the data that we see. So in the first round, when we are looking at the pilot, we're not making any change in the payment structure. So this is more a process and a feasibility pilot. So this will not affect any kind of incentives that you're already receiving.
So just to add to what Dr. Sudha has mentioned, I think we'll definitely look forward to your suggestions as subject experts in specific specialties to give us the right feedback in terms of if there are any suggestions on each of these aspects, like the timing of the measurement or the validity of some of the methods that we are proposing to do, etc. So we'll definitely absolutely welcome to all your suggestions. The next, we have a detailed comment by Jack. He's been always extremely helpful. And I completely agree with the detailed set of comments that you've also shared earlier. So we'll definitely work on all your suggestions, and I mean, I take them all in positive light. Thank you.
Just to add that to understand the landscape of this VBCs, I think WHO is already helping us to get some analysis or experiences from various other countries on this. So we will be learning from all the different countries that you have listed. These are novel strategies. Good to read some positive comments also. So can we have a system to create to monitor the payments done? There are hospitals for pending payments. Absolutely. I think this is beyond the scope of this discussion, but just to give response to it, I think in that sense, the monitoring of the payments are being done on a regular basis, on a daily, weekly basis at our level. But the final payments are to be done by the SHAs. So we have, no direct control of when the payment happens. But good news is we are testing out a green channel system of payments to the hospital, wherein right now it is being piloted for public hospital, wherein as soon as the claim is submitted, 50% of the payment amount will be, transferred to the hospital account. So that, whatever is the remaining after the adjudication of the claim, the remaining percentage would be paid. And if there is any difference, it will be recovered in the next set of payments. So in that sense, that is something that I'm sure with both all the public and the private hospitals are looking forward to it. So in private, we are identifying how to operationalize this. We'll be thinking about some kind of a bank guarantee or some kind of a backup strategy to implement these. So it's a work in progress. So we hope to see it sorted out soon.
There's a suggestion on some app that has already been developed by Indian Cancer Society for measuring the quality of life. So, Madam, I'll request if you can please reach out to us, and we can have a discussion with you on the kind of app that you have. We'll definitely see if there is some kind of synergy that can be generated. And any specific other information, there's the email has also been provided to you in the chat box itself, which is listed just almost two comments down below your ones. So it is hpqa.pricing@nha.gov.in, where you could reach out to us and we can fix up a time.
So we have not yet developed the app, so we don't know how, currently don't have any mechanism to assess that. But definitely as we develop that app and integrate it, we will be doing a lot of field testing and pilots to understand how it can, how the whole process can be operationalized.
There's a very interesting comment by Dr. Ajay Tandon saying that how will you adjust for the case mix? So we are very much cognizant of the fact that there could be differences in the levels of the type of patients. And we obviously know that patients, for example, even simply saying hospitals like AIIMS and PGI perhaps may have a higher maternal mortality than a district hospital, but just because they receive a severe spectrum of the cases. So What we are hoping to do in order to do that is that, because we also have consistent ICD-11 data that is also that has also been started to be collected on our TMS system, and this ICD-11 helps us to distinguish to an extent between the levels of severity, etc. So we will work. We are in the process of trying to develop some kind of a strategy whereby the case mix that has been received or treated within a given is also given some due consideration in the entire measurement framework. This is a great comment. We haven't completely articulated the exact methodology, but we're definitely we're thinking on those lines, and we'll try to work out a strategy.
Okay, so the next comment, I think comment already sent, but I think the next one is interesting. The Lancet Commission recommendation is that all birth, not just high-risk birth, happen at the emergency obstetric facilities and most of the neonatal deaths also within 30 minutes of them. So can't PMJAY give its benefit package include payment for normal deliveries? So I think we just released an OM to withdraw the normal deliveries, which actually we did feel it was a justified inclusion, but because there is also public sector which is already providing most of the care for normal deliveries. So there was a little bit of rethinking on that at the policy level. So we have currently withdrawn that. I think as of now we have not included within our list. It was not there even previously. So it was just an inclusion that we had proposed. So that has not been done.
Okay, so there's a comment by Sundar sir saying that there is a Lancet quote of attributes 60% of preventable mortality to quality of care, but the evidence that accreditation of different forms reduces mortality is thin. Quality accreditation still has importance, but a 50% incentive of what should be a baseline could be a problem. So so what we are trying to do actually is that we completely agree. So, and that's why we want to move out of simply, so currently it's like 100% of incentive being given based on accreditation. So what we're trying to do is we're trying to reduce the extent of incentive that is delivered entirely on accreditation, but at least have half of the incentive that is being given based on outcomes or patient satisfaction or the level of grievance, etc. We do also want that eventually we should try and increase the overall amount of incentive that a hospital receives based on the outcomes rather than just merely the accreditation alone.
So, and just to that, as we move ahead and as we mature, I think accreditation will become one of the component of the overall performance indicator. So there will be no percentage attached to it as such. So we are hoping that we will reach to that level sometime. How about measuring hospitalization that are amenable to risk factors to the health system quality? Yes, I think this is something we are exploring, and Ajay, you are also part of that. So in that sense, we will be looking at, and as we identify more insights from our analysis and things, we will have a check on disincentivizing hospitals who are not doing that kind of proper follow-up and causing readmissions, or even for conditions which need to be treated at a much lower facility level. How can we do the gatekeeping in a much different way? So we can explore different measures of how we handle this kind of patients that we will be seeing at our tertiary and secondary care centers. So this is a work in progress, and based on the insights that we develop, maybe we can see how to integrate such measures into the VBC also.
So just to add to what Dr. has mentioned on the previous point, I think it's a very fundamental thing which would be a measure of performance of the overall health system in a broader sense, and in the overall context of this continuum of care, but perhaps the way that the lens that we are using to simply look at the performance of the hospital, as you've also rightly pointed out, perhaps it may have a lower down the order importance. The next comment is very interesting, and it is that isn't the inclusion of readmission not subject to the same bias, same problem that the length of stay is, and hospitals may have an incentive to deny readmission. So the point is that the way that the readmission is estimated through our data, through our transaction management data, even if a patient doesn't go to the same hospital but goes to another hospital, provided if he is denied care in this hospital, even still it will be counted as a readmission. It is not necessary that he has to be readmitted in the same hospital. And secondly, denial to care would eventually lead to a grievance, because one of the most common reasons for patients raising a grievance is that they are denied care in a hospital, or they're sent back to say that we don't provide you care. So as a result, we hope that this second indicator that is also placed alongside, which is on denial to care or the grievance, is going to take care of this particular issue. The second is that HRQL in certain cases may not follow the same pattern. So it's related to the previous comment by Dr. Ajay Tandon, where we responded saying that we'll try to devise strategies to adjust for the differences in case mix, so that it doesn't disincentivize hospital that is seeing a more severe spectrum of the case. And lastly, it's the fact that it's again a question that I've somehow answered in the previous one, where you say that the stringency of no out-of-pocket expenditure might be worrisome, since optimum care may require some out-of-pocket expenditure. So as I mentioned, that as long as our prices are representative of actual costs involved in delivering care, the hospital should not be charging. And our attempt is as much as possible to align the prices to the actual cost of delivery of care. And once the DRGs also come in place, the prices will be sensitive according to even the patient severity and complication. So we hope that it should not be a problem.
So possibility of waiting time is including that might be difficult, because we won't know unless they hit the system as a part of a pre-auth. So we won't be having any kind of extent of the information that from when they were actually the first contact with the hospital and when exactly the pre-auth was initiated. But I think denial being turned away, denial is recorded as a separate thing in our grievance right now. I think this is a recent development. I think for a couple of weeks or months, we are having that kind of separate data on being denied treatment. So that would definitely is something that, but it is a part of the grievance matrix. So we don't need to do it separately. How they are paid, yes, we are looking at how they are being paid. So we will, and readmission, I think we have answered that question.
Okay. Next is, yeah, we agree that IT is going to be a very key thing. So some of the things have an IT integration right now. For others, we would have to do that. So we definitely, and in our operational roadmap also, I did mention that IT integrations would be very essential. We do not have an essential medicine list formulary that only mandate the use of generic drugs or anything on the monitoring of the selected patented medicines as of now. However, as we move forward, we are also trying to put in place certain mechanisms of strategic purchasing. And through those mechanisms of strategic purchasing, we are trying to ensure that we are able to set up systems whereby there is some price negotiation for drugs that may be drugs, implants, etc., that may have something to patent or likewise. In general, we prefer in our HBPs those medicines that have a generic version or that do not necessarily patented.
Just to add to that, the post-discharge medicine also, we are looking at how do we use e-rupee vouchers so that patient can buy the medicines in any of the Jan Aushadhi centers, and that will also promote the use of generic medicines at a much lower cost. Can incentives is added up? Currently, the incentive we have is cumulative itself, so it is added up.
Regional translations for HRQL, yes, there are probably more than 12 or 15 translations in Indian languages itself that are available for EQ5D, which includes southern languages, also northeastern languages. northern languages, North Indian languages, etc. also.
So yes, self-reported, both are subjective, whether the poor may report better health than they actually have. Actually, this we have seen in one of the quality study wherein patient interviews were done. And in most of the patient quality studies across the country, even including the Mera Aspatal. So there are many things that there is this over-reporting or under-reporting by based on the educational level. So that is some bias we need to see how to adjust for.
So there's a second comment by Dr. Sundaraman. I think again very pertinent comment that a lot of issues that also need to be addressed alongside as we talk about the value-based care, and a lot of these things related to fraud control and related to ensuring that there is no supplier-induced demand or cherry picking, etc. As much possible. There is somebody whose microphone is not muted. I
can hear you, Dr. Shankar, but little it was there was little change in the voice. And increase the volume.
Sorry, I thought there was a background noise. It's okay. So what I'm trying to say is that yes, there are. So we need to definitely make sure that in the entire connotation of value-based care, we also place enough emphasis on fraud control, on the kind of the supplier-induced demands that are taking place, and also have this kind of continuum of care so that there is not unnecessary tertiarization of primary care needs. So completely agree. Currently, the intent is only to measure the level of hospital performance. So that's why we've not included them, but we're trying to definitely tackle these issues at different other points when we're talking about fraud control, when we're talking of continuum of care, etc.
Yeah. So we are looking at using it proactively. To start with, yes, it is linked to understand the system, but post that to the payment system and then to the overall scheme implementation. So that is the progression of using these new initiative is value-based pricing leading to improvements in accreditation. So definitely wherever there's a financial incentive, there is tendency for hospitals to move towards it because they get something extra. But in the recent review of study, we did find that even though there is an incentive, not many hospitals are going in for accreditation, nor renewing the accreditation because maintaining the accreditation also is a lot of effort. So what we are trying to see is it may or may not lead to improvements in quality. So since we are moving ahead with beyond accreditation, this will be helpful. Yes, the patient reported OECD survey, that is something that we will review, but there is already a planned study, I think by World Bank itself, to look at beneficiary and reported outcomes for and satisfaction that is being planned in some of the state using some similar instruments from these surveys.
The next comment on out-of-pocket expenditure, that we definitely are trying to make sure that we measure exactly the way that you have articulated the expenditure that is incurred on the drugs, diagnostics and supplies, etc. from hospital or outside or lab during the current episode. So we definitely we will try to articulate also the question in a way that necessarily captures this particular issue. You're on mute, Dr. Sudha.
I was trying to make it very clear for you so that there's no background noise from my end. Okay. So thanks for the feedback, and definitely we are going beyond the patient satisfaction and looking at patient experience. I think that is a study that is in the pipeline.
Are you looking at hospice care? So what we have included in the recent package, a number of palliative care packages as procedures and packages as well, which are part of the which are delivered in a hospitalized setting. but hospice care is currently not within the benefit package of the PMJAY.
Thanks for the suggestion. I think this will help us to look at readmission outside our PMJAY ecosystem. Yes, call center can pick up to some extent, but exactly the reason, the clinical, the requirement of such readmission and whether it is for the same condition or not, we won't have a lot of claims data available with us. But it is a starting point so that we can review and do a much more deeper analysis of that.
So standard treatment workflow is currently also integrated with TMS, and it enables the medico to ensure that at least some of the check boxes that need to be made sure of, they are complied with.
Oral theoretical purchase from private sector was promoted. That patient choice of provider would help improve, or seems to have left that rationale. So I think currently also patient has the choice of which provider, but limited to the empaneled providers. So we are not beyond, but to some extent there is a gatekeeping also from the public to the private. Some states have introduced that gatekeeping so that they don't have a free to go to any private empaneled hospital, but they have to get the referral, not to a particular hospital, but get the clearance from public hospitals before they approach the private hospitals.
Next, we've actually answered this, that because it is not covered under the PMJAY, so we do not include the ambulance cost and the travel cost and the expenditure. This HRQL is currently not for pediatric age group, but not theoretically for pediatric age group. However, proxy responses are still continue to be used. There is a version that is being developed to be used for the younger age group population.
Yeah, there is a lot of training component involved, because we do have to orient the PMAMs and the call center executives who are collecting this information. Definitely, yes, we will be looking at how do we do the quality checks and the field staff who are involved. So to ensure that the data that they're receiving is of good quality.
There are questions.
So 35 questions, Shankar. So how do we do this?
35 more questions. No, I think we are at the end, I guess.
No, okay. 35 new messages beyond what
we are at the end.
We are at the end? That's okay.
Profiles, post-op support beyond the 15 days medicine for recovery, would this be considered? So as I mentioned, that some follow-up packages in cases where the follow-up care is required has been included now in the new health benefit package. The problem is that it takes certain time for it to translate in, functionally to be implemented at the state level, because the states make a decision to migrate to the newer versions of the health benefit package. That's why. So, Dr. Sudha, can you take up the question, please?
Yeah. In value of care, we are incentivizing the providers to report more pre-cancers and have measures. Okay. So currently we are not doing that. I think that's a part and parcel of the care provision with which hospitals and treating doctors empanel within our scheme. So they are supposed to follow the treatment protocol and refer the cases immediately. And I think as a routine, their clinical practice, if they have a good screening systems, then definitely they'll be able to pick up patients in the more precancerous stages. Okay.
I think thank you very much. This has been an excellent round. Please keep sending us more questions, comments, suggestions, etc., and we'll definitely respond back to all your suggestions. So we'll after 21st, we'll prepare a detailed responses of all these questions, including the ones that are here in the chat box. The team is copying each of these comments, and we'll post all the responses formally on our website. So, and we'll make sure that we revise our current consultation paper also into a policy document that takes into consideration all the suggestions that you provided.
So thanks everyone for all the suggestions and the feedback.
Thank you very much.